Ladies and gentlemen, are we nearly ready? Okay. It may feel a little overkill to be using a microphone tonight, but we're going to record the proceedings, if that's all right with everybody. The reason for that is that we would like to put the audio into a place that people who can't make it tonight can then access the same material that you've been able to. It does mean that if you're going to ask a question, and we hope that you do, we would like you to introduce yourself, and particularly if you represent any organisations or a group of people, that'd be great if you could do that too. If you feel uncomfortable about doing that, you don't need to, but it will be very helpful if you could identify yourself. Speaking of which, I should identify myself, and the panel will introduce themselves in a second. My name's Andy Mills. I'm an independent chair. I work for an organisation called the Consultation Institute, which is a body that works with health bodies and local authorities and utility companies and anybody who's got customers who use services and helps them with their customer engagement and their consultation processes on the basis of making sure that people who use services get a fair share of the conversation. And so that's really what I want to do tonight. I want to make sure that you get an opportunity to ask the questions that you want to ask, and that the panel answer the questions that you're posing of them. Could I ask the panel on that basis, just if they would say who they are and the organisation they represent? Would that be right to start with you, Carol?
My name is Carol Davis, and I am responsible for paramedic emergency services across North Cumbria. So that is as far as the west coast to the eastern border for the North West Ambulance Service.
Everyone, my name is Stephen Childs, and I'm the Chief Executive of NHS Cumbria Clinical Commissioning Group, and we're responsible for the consultation process.
Hi everybody, my name is Michael Smiley. I'm one of the directors at Cumbria Partnership Foundation Trust, responsibility for a number of the support services, finances, and for planning and strategy. We run services across Cumbria, the community services, including the community hospitals.
Hi, I'm Rod Harpin. I'm the Medical Director of the Acute Trust, and I've been asked to give you a short presentation of the changes we propose and hope that you'll engage in tonight.
Just before we do that, can we just get a kind of feel for who's in the room? I'm not quite sure what the collective noun for people who are from Appleby would be. Are you Apollonians or Applebyans? Are you all Applebyans? Are there any non-Applebyans here? And surrounding villages. Okay. Are there any staff members here? Anybody who works in the NHS? Fantastic. Marvellous. Thanks for coming. And what about people who are regular users of hospital trust services? Anybody here who's, I would say, using those services on a monthly basis? That's a great answer. Okay, just nice to get a feel for who's in the room, really. Rod, are you happy to go through the presentation? And then when you finish, we'll open it up for questions.
Yes, so as I said, we'll do a short presentation just to set the scene, and then over to Andy to sort of allow you to ask questions. So this is our proposal. It's a range of options around 6 changes. It's healthcare for the future, and this is the public consultation phase. So we do, as a health economy around here, and I hate that word, but as a health system for you as the users, face some quite big challenges at the moment. You only have to pick up the newspaper each day and you realize that those challenges in healthcare confront us all the time. So what are the big challenges? Well, first of all, overall population health is not good. Difficulty attracting doctors, nurses, and others. And that will come through the presentation as a bit of a theme, particularly for some areas in England, and particularly for North West and East Cumbria. This is an issue for us, is really attracting and retaining highly specialised staff which we need to run our services. Too many hospital admissions and long stays, and we know that our statistics in terms of hospital admissions and numbers of patients who get admitted rather than stay in the community is higher than average. Also, we know that our services within our hospitals and our community hospitals have longer stays. The NHS is significantly overspent. This local health economy is overspent, so we have the dual problem. And some of our services, some of them, are judged by our regulator, judged by our regulator as being inadequate or needing improving. So that's the challenge that we face as a health system. So now's the time to embrace change. We need to tackle the difficult issues. So this consultation is about us suggesting some options for tackling the difficult issues. We need to take some important decisions, and we encourage you to join us in tackling or taking some of those important decisions. And that's your role in part tonight. We have a compelling vision. There is something unique about this area. It's a very beautiful area of England. It has some qualities. One of that is its population density. So it is our vision that this should be a centre of excellence for integrated health and social care provision in rural, remote and dispersed populations. Now, first of all, although it's not really part of the consultation, the main theme underlying the move to improve services is that we will provide care within, if you like, community hubs. So those community hubs have been chosen to be called integrated care communities. They are communities of somewhere between 20,000 and 70,000 population. They involve really all your healthcare providers in the broadest sense getting into one small system. That may be a building, it may be several buildings and ways of delivering care. And that includes NHS providers, social care and voluntary sector. One of the main themes about the next few years will be getting care in the home and basically keeping people away from hospital beds. More people remain independent for longer, and we know that admitting people to hospital is not the right thing to do in many cases. So reduce the need to attend or stay in hospital, and as we will understand, the health service needs to invest in, if you like, technology and use technology to keep people healthy and look after them in these community settings. So that basis of your healthcare system, plus the changes I'm about to go through, are what we're proposing. So safer services, we need to deliver safer services. The quality needs to be improving all the time. We talk about this expression, clinically sustainable, what your health economy, and particularly sectors of it, have gone through is periodic crises in staffing, technology provision, and we need to make sure that we're not concerned about the people to deliver your services and that we can get on with improvements. And financially sustainable, it's a fact of life that has to be delivered. So what are the potential services we're consulting on? Children's services. Children's services are delivered in a different way these days, and people, it's perhaps difficult to understand, but once upon a time you admitted children for overnight and days on end. Now in some parts of England who have adopted new models of care, you only admit about 3% of children. The rest are placed in either short stay assessment units or literally treated for a little while and then go back to their community. And that's the right way of treating children. They don't need to be admitted to hospital. Some do, and when they are, they need to be in very specialist centres, either in a main district general or a tertiary centre. So what we're proposing is a range of options. Option one is inpatients at CIC, Carlisle, and Whitehaven, but only low risk at Whitehaven. Inpatients at Carlisle with short stay assessment at Whitehaven and full consolidation at CIC. Those are the three options. Maternity services, antenatal and postnatal care carries on where the consultant-led units and the maternity units are based. So option one is consultant-led maternity care at CIC and Whitehaven. It's important to emphasise that because of some of the paediatric changes, that some high-risk mothers and babies would be moved, even under option one, to Carlisle, distributing about 200 of Whitehaven's current deliveries to Carlisle. Number two option is a midwifery-led unit at Whitehaven, and that would be the only option in terms of delivery there. And then option three is full consolidation at CIC. I forgot to point out the paediatric preferred option, but the preferred option, I think, in the documents is option two. Community hospital inpatient beds, different consolidations. When we get to question time, I'll hand over to Michael and others to sort of explain what these different options are, but essentially option one is the preferred option, which would be consolidation on 6 hospital sites. There are reasons for that, and it's around grouping or clustering numbers of beds in convenient numbers for nursing. The other options are 5 hospital sites, a different 5 hospital sites, and then coning it right down to 3 hospital sites. Emergency and acute care, essentially providing outpatient and elderly care on both Carlisle and Whitehaven in all options, but option one, which is the preferred option in the consultation document, would be 24/7 emergency service at Whitehaven and Carlisle. The other two and three, would reduce the delivery on the Whitehaven site, and it's still our preferred option to deliver a full 24-hour service on both hospitals. Hyperacute stroke. The treatment of strokes is changing, and stroke physicians are believe it or not, rare commodities these days. We hope over the next few years that will increase, but the tendency is to very much focus stroke care into what are called hyperacute centres. In other words, centres where some of the services you need to improve the outcomes are focused. And so to improve stroke outcomes, then the proposal 2, which is a dedicated hyperacute stroke service at Carlisle, would be the proposal. And that would, in essence, mean everybody would be moved to that site to receive their stroke service and also have the support services that go with that. Definitely get down to the money. The overspend at the moment is 70 million. That's in this health system, Northwest and East Cumbria. If we don't do anything, and I would emphasise that the clinical changes are a very small saving in this, but if we don't do anything about the current spending, then that will balloon out to about 163 million in 2020. And we know we can save money by more efficient working and new ways of working. And it's important to emphasize through this consultation, the clinical changes we're proposing are not the main driver, not financially driven per se. The savings you get from the clinical changes are not a big part of this. So what is the future for West Cumberland? There's a lot of concern, obviously, around this. Some acute surgery returning, so we would put back some lower risk acute surgery. Some trauma returning, bringing services back to being more local, where the risks are not great. More planned surgery taking place, getting our surgeons and our anaesthetists to put more work through the newly modernised Whitehaven site. Major new diagnostic suite is planned so that you can get elective diagnostic work more readily and to hand for the local community, and more people treated at Whitehaven than before. So this plan, whilst it shifts some of the more acute elements of care towards Carlisle, it also does return some of the less acute work to Whitehaven. Over to you. I think I need to explain or get Stephen to explain really the basis of the consultation.
Thank you. Good evening again, everyone. Once more, my name's Stephen Childs, and I'm the Chief Executive of Cumbria Clinical Commissioning Group. And I just want to say a few words about the consultation process to help you with your understanding of what's going on over the next 3 months, and which you are a really important part of. So I think the first thing to mention and to stress really is that this is the culmination of an awful lot of partnership working, and the consultation itself is, as you can see tonight, a partnership effort of the main NHS organisations across our region. Although the success regime is understandably very closely associated with the planning that's been going on, facilitating the conversations between agencies during the engagement phase, it's the Clinical Commissioning Group, Cumbria CCG, that has the legal responsibility to deliver the consultation process. But we work very, very closely, again, with all of our partner agencies, including colleagues in the success regime. I wanted to give you some idea of the scale and the comprehensiveness of this consultation process. It's not fixed, so suggestions may come up tonight as to how we can further improve it, and we would very much welcome that. But just to give you a feel of the current scale and, as I say, comprehensiveness of that consultation. So, for example, we've printed over 7,000 consultation booklets, and they've been distributed through as many public buildings as we can possibly find, be it libraries, GP surgeries, local authority buildings, hospitals, etc. We understand that some of those supplies have run out, so we're replenishing them. Extra print runs, we're distributing the documents through these events, obviously, as well. We have 17 public events planned, but that's only the tip of the iceberg, really, because we want to make use of existing meetings, particularly those groups that perhaps don't engage that often with health services. So we have over 50 of those engagements lined up in the coming weeks, and we're continuing to search for those groups that would like to meet with us, who may not have thought of doing so at the moment. And engaging with the voluntary sector, the CVS, is another fantastic opportunity to listen to people and to discuss, if they would like to, the changes that are being proposed. It's perhaps just worth putting the consultation technically into context. It's not a referendum, it's not a vote, but I don't want you to underestimate just how important your views are. So everything that is told or explained to us through this meeting and all of the others, or written down, is taken into consideration at the end. So to give you some idea, just a couple of weeks in, we've had over 900 responses. These are all gathered up and they will be independently analysed. But it's not the only consideration. We need to factor in the views of clinicians, the views of staff in these hospitals, and also the financial implications. But as Dr. Harpin said, we wouldn't want anyone to think that finance is the driver behind these proposed changes. Fundamentally, first and foremost, it's patient safety and the quality of services that's driving the change. So at the end of the consultation process, again, just to repeat, independent analysis of all of the feedback we've received, presented to the clinical commissioning group in the new year. We will obviously discuss the findings with our partner organisations before the clinical commissioning group will make a decision, probably around the early spring. And that will be the end of the consultation process.
Okay, I think there's a final slide that's got the details of the website. Because I was just going to ask people, how many people have accessed the hard copy of the consultation document? Have you seen it? Great. Gentleman's used his printer ink up there, printing that off, I would have thought. If you want... Right. Right. Well, we need to put that right in terms of making sure that if any of your friends and colleagues need copies, we've got hundreds and thousands of them at the back of the room. But perhaps just as usefully, if people have got access to the internet, and I understand that not everybody has access to the internet, but there's a website, and on the website is a massive information. It's a point that I think we've talked about with various panels about how accessible some of that information is. I think the business case is on there, and I think it's 206 pages, which will keep you awake at night if you're going to need something to keep you awake at night. But hidden within that documentation is a lot more information, which is really interesting. I think one of the lessons learned is to perhaps get some of that information out and make it more accessible for people. So there are kind of 5 areas that are covered by the consultation. Just to get kind of gauging the interest in the room, looking at those in turn, have people got questions about children's services tonight? Maternity? Okay. Community hospitals, inpatient beds? Yeah. Emergency and acute care? Or hyperacute stroke? Okay. Well, I presume somewhere there's some generic questions in there, perhaps. Otherwise, we're going to be out of here in about 10 minutes. We want to work the panel hard, so think hard about questions that you've got. But shall we start with children's services then? Because I think we had at least one question that was coming from there. No? Did I get that wrong? Was there a question on community hospitals then? There we go. Sorry, yes. Would you mind using the microphone?
I think before we go further, I think we need to realise that I think a lot of people here are not quite sure what these proposals potentially mean for them. The slides are simply, the only hospital they referred to have been Carlisle, which is used mostly here, and the West Cumberland, which is hardly used at all. I think a lot of people are going to be wondering about Penrith Hospital, which hasn't been mentioned. So I think that obviously comes into community hospital, but I think people are going to want to relate to what they're familiar with.
Okay, so, would the panel like to cover that in terms of how this particularly affects the people of Appleby then?
Thank you. Is that working? Yeah. The consultation on the changes that have been outlined just now, I guess, are the specific issues that we're consulting upon, but the more general context that we're trying to make sure we set out for the future is that we want to try and ensure people are independent for as long as possible with the support they need close to where they live, where we can do that. We want to do that with the local authorities' services, the social services, where we can. So we want to develop integrated services with our local authority partners so that health and social care is seamless for people and where possible organised as locally as it can be for them. The proposals around the community services in this document are that the preferred option is to continue to have the 24 beds at Penrith compared to the current 28. And the reason for that is because the way we staff the beds means that we try to have one registered nurse professional to every 8 patients. And at the moment we have a different number that's not quite in that proportion. So we're trying to get all of our community hospital beds to be the right number of patients to the right number of registered nurses to give the best possible care we can in the most efficient way we can. However, in this area, the proposals include not having community hospital beds as they have been in the past, provided at Alston in future. And that's obviously a very big change. We think that's appropriate because if we integrate our services in the community with the local authority social care and the GP practices where we can and have joined up working, we think we can provide more care at home for people overall, and that helps them remain independent and well. And we also think we can do more to help people before they become ill, have better planned care to avoid crises occurring and avoid them having to go to the main hospital at Carlisle, if you like, in an unplanned way. So we're trying to get ahead of the problems people can encounter by being more organised around them providing care plans and the appropriate approach to care in the first instance. But when people do need support, doing that as seamless and as joined up way as possible, as close to home. We have had real difficulty sustaining our services across all of the hospitals, including locally at Alston and at Penrith. And earlier this year, we unfortunately couldn't sustain the service at Alston and for a period of time had to close the beds there. That's largely down to staffing, in the sense of trying to recruit staff to isolated units to work in a way that's not as supported as staff feel they want to be supported in their clinical care, or not necessarily as flexible. So in where we can in remote places, we want to try and provide more flexible opportunities for our staff, where they can perhaps provide care going into people's homes, do more care for people who are accommodated where possible in things like extra care housing and those sorts of schemes where they exist. So these changes and these proposals are the specific things within the overall context of more joined-up care wherever we can. And that's quite tricky because there's a lot of staff delivering services now, and organising that is quite a tricky thing to do, but we've got a really strong consensus from the clinicians and from our partners in the local authority that it's the right approach. We're currently consulting here, and I know there's currently another consultation underway by the local authority about their services as well. And certainly a colleague raised the matter with me earlier today as to wouldn't it have been better if we'd perhaps joined up the consultation. For various reasons that wasn't possible, but with regard to the plans to provide the integrated care that Dr. Harpin mentioned, we have been doing an awful lot of work with our local authority colleagues so that where possible we can get the two services working hand in glove wherever we can. So that's possibly a more context, if you like, and to what it might mean in terms of for people locally. As I say, in this area, the hospital beds particularly affected by the consultation are at Penrith, where we're looking to continue to provide 24 beds compared to the current 28. But at Alston, obviously, a big change there planned. And the preferred option we have is to maintain 6 sites for community hospital beds, which from all of the options is the one with the most number of sites provided.
Would it be possible just for the panel to say a bit more about how you've arrived at some of the kind of modelling that you've done to get to the numbers that you're talking about? Because I think it might help people to understand that perhaps it's not just you 4 that are doing all the work here. There's a group of people who are behind you and perhaps some of the people who are kind of working with you nationally around some of this agenda. Would that help people to understand how these numbers have been arrived at?
Yeah.
You know, if they could explain that, because I
Okay.
think it's not very clear.
Okay.
My worry is that we had care in the community once. Same thing, it sounded lovely. It didn't work because there wasn't enough money and there weren't enough people. And that's really what worries me about this.
Okay.
So convince me that integrated care works.
So two questions really. A bit more about kind of how you got to the numbers you got to, but perhaps more importantly, because the audience have asked you, tell us a bit more about this ICC business, the Integrated Care Communities.
Yeah, we'll share the question between us and see if we can meet your challenge. Over a number of, about 9 months, I would say, we've had really quite active work done by large groups of clinicians coming together and social care professionals where possible to think about how we're working now and how could it be better. And to do that, they've taken reference of what works well elsewhere, other parts of the UK, other parts of England that have got better results than we get in terms of the way things work, but also internationally, because our part of the world in England isn't the same as the rest of England. So there are places in Alaska, in New Zealand, in Scandinavia that are a little bit more like the sort of communities we have in Cumbria. So we've looked at those examples too. We've considered a large long list of options, so the current state as well as the options for how things could be different in future. And then we've gone through quite a rigorous number of meetings where we've tried to consider the best of those options, scored them where possible, and come up with which overall is the preferred options for this consultation. So there's been quite a long process of doing that with quite a heavy involvement from large numbers of clinicians across Cumbria, across, I should say, West, North, East Cumbria. It hasn't included everybody, so that's why it's very important that having got this far, we do the consultation process so everybody gets the chance to have a look and have a say and think about things. There's the consultation document, and in addition, there are quite a large number of fact sheets about each of the specific areas. There's one on community hospitals here, and there's one on integrated care too. I'd certainly recommend for you to all to have a look at some of those in detail if you want to find out a bit more. About integrated care, perhaps I'll invite Rod to perhaps respond in the first instance, and we'll contribute after.
Okay. So, sorry, get closer to the mic. So, integrated care, that's the locally chosen name. There are a number of ways this is delivered around the world. I have some personal experience of delivering it in another country, one of the ones Michael was alluding to, which is New Zealand. But let's look at the constituents of what is possibly in an integrated care centre. First of all, I think one of the exciting things that's going on at the moment is to get social care and conventional medical care in the same either virtual or real building as physiotherapy, re-enablement services, benefits, taking people through what they need to cope with life at home. So there's no single recipe. The main aim is to target populations, groups of individuals who need very special care, keeping people out of hospital, in their homes, or for short bursts of care within a hospital, and targeting them back into the home. So it's very difficult to give you an absolute recipe, but the main thing is the notion that people will come together as multidisciplinary teams. Now, no, they haven't, and that's the important point of this. Now, you know, there are groups of, as you quoted Millam, there are groups of people coming together, including the GPs, particularly GPs, physio. I think the changes that are occurring with social services, social care, coming more aligned with healthcare, and particularly in pooling them. the funding basically to make this work. I think that the Millam project with John Howarth, Professor Howarth, who is part of, I might come to the other exciting thing going on in this region, but targeting in getting to people who with some assistance can stay out of hospital, and they've reduced their hospital attendances by something like about 13% from that area. So that's what's behind ICCs, and there's nothing new about it. And can it be made to work? I think this is the time. If it's going to work, this is the time to make it work, and it almost has to work, because otherwise the costs of keeping up the current model of hospital beds in major centric hospitals just won't work anymore.
There's a lady here that's got a question. If you hold on one sec.
Right.
You haven't really answered all my questions about integrated care communities, or really satisfied my concerns in what you're saying. Basically, your vision of an integrated care community sounds very much like a kind of bumped up version of the health centre we already have at Appleby, which covers a wide range of services. The main problem is that if people can't get an appointment to see their GP for 2 to 3 weeks, inevitably they spend more time going to A&E, because they either become acute or they become afraid, and so they take the option of going for emergency care. And until the primary care element of this has been addressed with the primary care trusts, I don't think you're going to see much improvement. And I would like to know more about how you are going to involve the primary care trusts, since some of them are, I know, privately financed already.
Perhaps I can help. I mean, just for the benefit of the audience, the primary care trusts ceased to exist in April 13. But they were replaced by the clinical commissioning groups. They are subtly, significantly different entities because of the strength of clinical leadership within those organisations. The member bodies of the clinical commissioning groups are all of the general practices that exist within their catchment area. And that is fundamentally important to the future of the integrated care communities, because, as you quite rightly point out, primary care, general practice, is at the heart of the integrated care community principle, philosophy. Because at the moment, you're right, sometimes under one roof, sometimes under a number of roofs within a town, you will find all of these services. They all exist. But unfortunately, perverse incentives in the way health and social care organisations have been set up pulls those people apart more often than not, even though they're trying to meet the needs of the same patient. And I think there is a movement, the kind of which we've never seen before across health and social care, particularly in this community, to bury those organisational differences, because we've reached a point where the status quo simply cannot go on, because our hospitals are imploding with the pressure, that people now leading these organisations are saying, and led by general practice, are saying we need to pool these resources in the community, we need to integrate, and we need to mobilise them around the needs of the patient, not the needs of the organisation. So I have witnessed in my previous years in the NHS attempts to create multidisciplinary teams, sometimes with social care as well, and they floundered despite good intentions. But there was never the pressure in the system, the likes that we have today. We simply cannot sustain the services we provide currently, the model of care that we provide currently, much longer. And fundamentally, that model of care hasn't changed very much since the origins of the NHS in 1948. And yet, virtually every other facet of our society has moved beyond recognition. So there is an absolute imperative that we have to mobilise these resources in the community around the needs of the individual patient, bury the differences between organisations, and ensure particularly those most vulnerable and frail, those with long-term illnesses, get as much of their needs met in the community, which, as Dr. Harpin said, prevents the need for that patient to be admitted, or if they do need a period in hospital, we are able to get them out of hospital much more quickly than we are today. So many of our beds in hospital are, and I don't like the word, but blocked because we can't get the patient home. And that, in turn, creates a pressure for those that do need to come in and receive care in a hospital bed.
Lady here.
Thank you. I'm very reassured that that you envisage the care in the future will be a lot more patient-centred and about meeting patients' needs where they are. That sounds very, very good. And I agree that often it's not the wish of patients to be in hospital, especially when hospital is a very, very long way from home and you've got family at home and you're away from them in hospital. In Appleby, we are at least 30 miles away from Carlisle, and I wouldn't even like to guess how far we are from Whitehaven. But I notice on one of your options for maternity services is to have a midwife-led unit at Whitehaven, and I didn't see anything there about midwife-led services anywhere near us in Appleby. And I wondered if you could just speak about that, please, because obviously the stress and the inconvenience of having to go up to Carlisle for services, or even Whitehaven, would just be completely unacceptable for a lot of mothers in this area.
37 miles.
Thank you. So, I mean, it's a fair trek to go all the way over there. So I wondered if you could just speak about midwife-led maternity services and what that would mean for women in East Cumbria, please.
First of all, there's no intention to remove the Penrith birthing unit. That's not on there, but that remains. So just to make that clear. Alongside, I mean, they're progressions, they're changes which should be made anyway. If you read the Cumbria report, which was a report into choices in pregnancy and delivery choices, then alongside the Carlisle unit, there would be a midwifery-led unit developed. But I take your point that bringing other units like that. Now, one of the suggestions that I've heard during the early phase of this consultation was, for instance, why didn't we consider more community midwifery support for home births, for instance? And that would be seen as a progression of our current system. And I think something that West, North and East Cumbria is behind in is providing some of those choices, giving women information on how they can give birth, in what settings, and what are their risks of doing that, because there's different risks depending on whether they're first baby, second baby, whether they've got their own risks with their twins and things. So I think behind this is the high level, what are the major changes we're proposing, and obviously that's a major change to remove the consultant-led unit from Whitehaven. But alongside this, and with the midwifery liaison group, it's imperative that we actually develop the other choices. So I don't know whether that helps answer your question. What we can't do is put a consultant-led unit in Penrith Hospital, because no.
The Penrith birthing unit will remain,
yes.
And maybe a possibility for the future might be to develop more services to enable women to have home births in this area.
Yes, basically community midwives who are really well trained already, but improving the relationship between the hospital and community so that they essentially rotate. I mean, my midwifery colleagues have got some ideas, but that would be seen as part of developing options anyway, and it's not really needed in terms of consultation. But can I assure you that there are, particularly our midwives are thinking about how they can provide those sorts of services.
Well, that's very reassuring. Thank you.
Okay, do we have some more questions? Is it gentleman with the blue jumper on?
Hello. For the past 2 years, I've been involved with trying to sort out the car parking at Carlisle. So I know a deal about how the system progresses relatively slowly. When I burnt this off, I've got to say, my first reaction was, is that all there is? And when you look at the area that we live in here, then what you're consulting on essentially doesn't really affect us here. But it's what's not in there that does affect us. And hence the interest in integrated care. Now, we live in an area where there's no real public transport. So even if you have care in Penrith, it's inaccessible. And we've got we've got certainly above average single people properties, single households. So if there's any illness in there, then getting them back home is going to be an enormous problem. I've got no problems with your dreams. My issue is, and I believe, they are largely impractical. It's going to be much more expensive than you're envisaging. It's not a freebie. And as the lady here says, we had something like that before. I've got no evidence here of any involvement with the local authority. You assure me behind the scenes there is. So really that's a failure of this consultation. It doesn't tell us the proper story.
Colleagues were talking about Millom, and it's a shame that John's not here because John's a working clinician in the Millom locality, isn't he? But do you guys know enough about that to say that's been kind of at the heart of what you're trying to achieve with these integrated care communities? And perhaps saying where the footprints are that you're thinking that these might relate to? Because presumably one of those will have to...
I'm going to say, if I may, I mean, that is all sort of reinforces my comment about the consultation. We don't have enough information to hand to be able to sort of comment realistically about it.
I'll just point one thing out and then hand over to Mike. The integrated care communities are a really important foundation for the future delivery of care, but they're not actually what's being consulted upon. So in some respects that to a degree explains the lack of detail, but I do take your point. We need to fill that gap quickly. The consultation is on the service changes that Dr. Harpin talked through a little bit earlier. So just to put your minds at rest, the integrated care communities, it's great to get your views, and we absolutely take away the point that you need to have more detail about how they will work, and that will be forthcoming. But to put your minds at rest, that is not actually part of the consultation.
Thank you, yes. Move that closer, thank you. So the work we've done so far ahead of this consultation, particularly around Millom, came out of a bit of a crisis. We couldn't sustain all of the services that we were running at Millom, which is a very isolated place. And there was, you might recall, there was quite a crisis of confidence in the services locally. And through that, what we did was we formed a plan with the local community. Millom is a place of about 10,000, 11,000 people when you look at the whole area of that part of the world. And so one GP practice. And so working with that community, we tried to make best use of that crisis. And we did a number of things. We, first of all, were very honest and open with the community about the challenges we were facing. And at that time, we couldn't recruit GPs, and we couldn't maintain all of the staffing in the local services. So the community, I think, appreciated that openness and started to work with us on some of the solutions. So we've created a number of initiatives where we're trying to help the community be as healthy as possible. So, for example, some of our clinicians have been into the school, working with the school children, and asked the school children to take back messages themselves and to their families about healthy eating and exercise and those things which actually do make a difference and do keep you well and can affect your long-term health and we know makes a big difference. Things like stopping smoking, for example, has a major impact quite quickly on improving our population's health. So we've got a campaign running in Millom with the community run it, we don't run it, about being healthy, which is a really good start. We've also done a campaign with the community about how best to use your local services. Don't just use your GP practice, use your pharmacy. Think about the type of common ailments you might have and the solutions to that. Those types of things which making best use of the types of things that exist in that community so that as much as possible we get the best for the resources that are there. And that's trying to make the community much more conscious of not just its own health, but how it can get the best out of services, health services. And then finally, the work we're doing in Millom is about working together, so ourselves and the community services, the GP services, the social care services, think about the population there. And they've looked at, well, who are the most vulnerable in this population? And how can we get ahead of those vulnerable people finding themselves in a crisis? How can we plan care better? How can we try and make sure that those people are kept well so that they don't find themselves in need of urgent care or emergency care? And that's really worked very well. As Dr. Harpin said, that's resulted in a significant reduction in people going to A&E from that area. It's resulted in quite a lot of people not needing to go back for repeat outpatient appointments, which has been better for them because it's a heck of a travel from their local community to their local hospital. But it's also meant that the hospital has been freed up to do other important things, and it saved some money. And then finally, working with CHOC, we've got going a scheme whereby there's a digital video link between the CHOC setup and the local GP practice and community hospital clinic, where people can go and actually not have to travel out of the town to go to their local CHOC centre. So using digital technology, we're trying to bring services to the town rather than what was happening before was people having to go to the CHOC centre a bit further away. Now, there are some analogies between what we're doing there and what could be possible here that we'd like to try out and bring here. So that's the sorts of practical things that we've made work at Millom. Still early days, but the results are good. And certainly it came from a crisis, and I wouldn't like to claim it's all solved, but I have to say the positive momentum that's there is a real community effort where the services, the health services, the care services are very much trying to work with the community to make those relatively simple improvements, which I think, as was said before, when people break down the barriers, you can actually get things done. I think probably the most impressive thing for me about Millom was when the school children in Millom made a little video on YouTube with their class teacher, and they were actually singing a song saying, "Come and work here." And the GPs put that up as the way to recruit GPs to Millom. So, the sort of the heart of the community really getting behind things. And I think, as I say, when you break down those barriers, it's amazing what can be done. So that's the sort of practical stuff that we're looking to do behind these proposals. I think the consultation document couldn't necessarily get across some of the things I've described as powerfully as they clearly are, but do have a look at the extra information on the website if you have a website, if you can do that, because there's quite a lot in the background information. And I urge you to have a look at the Millom Alliance website too, because what I've described is on there as well if you have an interest in that.
Is it just me that doesn't know what the CHOC is? What's a CHOC?
So the Cumbria Health on Call, that's where the CHOC comes from, is the out-of-hours doctor's service. So people who need a primary care doctor, a general practitioner, or a nurse practitioner for an urgent issue when their GP practice is closed, they would go to the CHOC service for that.
Okay. And I know at Millom, the ambulance service is very heavily involved. Carol, you've sat there. Would you like to say something about?
Yeah, we have an advanced community paramedic based in Millom, and her role was originally specifically to become part of that integrated care community, and she has done very well, including a lot of education, like into schools and things like that, about better health. about reducing hospital admissions, which isn't confined just to the Millom area. That's right across North Cumbria. We have, on a daily basis, we manage to deflect about 35% of people who would ordinarily have gone into hospital. And that is, and I know I'm deviating a bit from the Millom initiative particularly, but it's prevalent everywhere. Excuse me. And we would do that by what we call either hear and treat or see and treat. Hear and treat is where we can solve someone's problem over the telephone, because it could just be that they've rang us because they don't know who else to access, so we would point them in the right direction. See and treat is where we would go to their home following a 999 call, and we would be either able to treat them in their own house and then leave them with a message really to go and see your GP or not sometimes, or we would be able to give their GP a call and access other more appropriate services. But I think in Millom there is a plan, hopefully, to also physically relocate the ambulance station as well. So it's fully physically integrated. Millom isn't my area. It falls under the Morecambe Bay sector, so I can't talk about it fully. But I do know that our advanced community paramedic is making great headway there with a plan to try and roll that out in East Cumbria at some point in the future. It's about capacity really to do that on staffing.
Okay, I think this gentleman here had a question. Slightly different question.
Well, actually, you've gone some way towards meeting the first point I wanted to raise, which is that I think people are bound to try and relate the success regime of the future to their own experience, their own concerns, and be asking themselves the question, well, what difference would this make to me, and how would things be different for me in future if this happened? And you've gone some way towards dealing with that in terms of where would I go, who would I see, who would see me. The second point, I think, is a very specific one. It does relate to consultation. I think, given recent experience in this community, people would like assurance that the consultation actually has a meaning and that it's not simply an exercise which they will go through and then be ignored. Thank you.
And this comes up fairly regularly, the integrity of the consultation process. So just to repeat, all of the feedback that is gathered in, no matter how it's articulated, will be independently assessed and combined with other considerations, for example, clinical views, professional body views, shared with partner organisations, and then the governing body of the clinical commissioning group will make a decision on the basis of that analysis. So all I can do really, sir, is give you my word that no decision has been made. Absolutely not. And it is down to the governing body to consider that weight of opinion, independently analysed, to help it make that decision.
Can I just ask what kind of evidence that you would want to see that your voices have been listened to? Because I think it's unlikely you'll be able to find your particular question and the response that the redesign has answered in a way. So what would be your kind of desire to see as an outcome from the consultation? What would you want to see change? Okay. So from the independent side being?
We're told that it's going to be looked at by independently. Perhaps we could have sight of that independent report into it.
You would post the documentation online, wouldn't you?
Yes, John is helping me here with because John and his organisation have been commissioned to help us with the consultation process, but that would be our intention. That's correct.
Okay. Was there a different question? Great.
I'd like to go back to some of the points that you had on the presentation. Quite a number of those options that you had listed under several headings seemed to indicate a definite downgrading of the West Cumberland Hospital, and that most acute care, if certain options are followed, it would follow that most of the acute care would be delivered at the Cumberland Infirmary. Now, I know that that hospital is already very, very busy, and obviously, if more care is located there, it's going to present a significant challenge for that hospital to cope. And I know at times that it's had several wards. At one point, there were 2 wards closed at once for infection. How is this going to be managed? That's my concern, that those options are going to be taken, and it is going to be very, very difficult to manage given the funds that are available.
No, it's a very important question, and I suppose part of refocusing a lot of the elective work back to West Cumberland is an important part of this, because we recognise that we can't just absorb work onto that site and not return work in 2 ways. First of all, if we don't get the ICC gains or the Integrated Care Centre or the gains in the community that are necessary as social care and community care work together, if we don't get that gain and get patients flowing through our hospital and out again, then obviously we struggle with beds. So you're quite right. So we need that part of the equation. The other part is, as I've mentioned, we need to move a significant amount of surgery to those largely resident in West Cumberland, not the complex surgery that we've made gains on in terms of quality and improved outcomes, but the lower risk surgery needs to come out and be done at West Cumberland. So doing that and moving also a significant amount of outpatients delivered closer to home, so having our clinicians doing more clinics out, particularly one of the reasons why we're so attracted to the ICC model in terms of using the buildings and things, is to deliver a lot more outpatients out there in the community rather than having to come all the way into hospital, onto a hospital site, which somebody remarked about the parking took 2 years to sort out. But I mean, you know, it's these practical realities. So delivering that part of care, the low technology care that can be delivered, and also using some of our technology, like video links. We've now got virtual fracture clinics where people can be seen one end of the at West Cumberland by an orthopaedic surgeon in Carlisle. So our plan is that we know we're going to have to bring work in to the acute site as we're sort of very much focusing it. But importantly, we do have to get work out as well. So that's recognised.
Oh, I wonder if the panel could say something more about the kind of financing of the ICC, in the sense that, as I understand it, if we repatriate services out of, or activity rather, out of the hospital sector, we'd reduce the number of people who are using the hospital. Some of that resource can be recycled to actually fund some of the activity that you want to do in the integrated care communities. Is that correct?
We've got to remember that a lot of the resource is already there in the communities. The people who are providing services that we've touched on already are very much in those communities, but they're not necessarily coordinated in the way we as patients would like them to be. And so that fundamentally has to change. But you are absolutely right, Andy. In due course, as we reduce demand on secondary care services, we would expect a proportion of the resource we free up to transfer into the community. So there's a movement of financial resource as well as a movement of workforce from what we call secondary care settings, the hospital setting, to provide services closer to the patient in the community. There probably is still the need, though, for some set-up funding to pump prime some of these changes. So I won't pretend it can all be done within existing resources, but fundamentally, the day-to-day running of the service, the resources are there within the health and social care sector.
Okay. There's a lady here who asked a question. Is anybody else kind of warming up to the task and thinking that they've got a burning question? There's a gentleman there. So can we go with this lady first because you're close, and then we'll come to you next and you afterwards. Is that all right?
Could I just ask you to say what sort of time scale we're looking at here? Because you kind of, you haven't really said that. So, you know, how long would it take for this consultation decision to be made, and then how long would it take to transition to kind of what you decide to go for in the end? I mean, is it going to be 5 years, or, you know, sooner than that, or what are we looking at really?
So let me just try and break that down a bit for you. The consultation itself is 3 months in length, and I think we're in week 2, 3, week 3. As I mentioned in my brief presentation at the beginning, we would need time after the consultation closes for the independent analysis to take place. So we anticipate being in a position in the CCG for the governing body to be making a decision in the early spring of next year. So any changes to the services that are being consulted upon, the changes would follow, and I'll hand over to Rod and Michael in a moment to give you some idea of what they're anticipating, depending, of course, on what the outcome of the consultation is. But when it comes to the integrated care communities, they're not part of the consultation, so that planning is happening now. So we've identified the footprint of the 8 integrated care communities. We have strong indications of who the GP leads will be within each of those, and that thinking, the planning for how those communities will come together is underway. So we've talked today about the health and social care professionals that will be part of those integrated care communities. An awful lot of work also needs to be undertaken to think through the pathways of care that patients move along at the moment. How might they change? So our clinicians across mental health, community, primary care, secondary care will be coming together to discuss those pathways of care as they exist today, what needs to change to enable us to make these integrated care communities realise their potential.
Obviously, it depends which of the changes you're talking about and the lead-in time. So, I mean, and which options are eventually the outcome of the consultation. So, for instance, some of the changes in acute medicine, the emergency department changes, we know we've got a burning crisis for the medical model anyway, and so we're developing quite an exciting and pioneering model using physician associates. But that has about a 3-year training lead-in time. So the most of those changes would take 3 years. The maternity changes depends on the scale of changes, but we're talking 1.5 to 2 years, almost certainly. We'd have time involved with our ambulance partners sorting out the dedicated ambulance which we're proposing between the Whitehaven site and Carlisle. The hyperacute strokes, that could be done quite quickly as we would bring in the stroke physicians in some way into one site. So it very much depends which model you're talking about and what the outcomes of consultation. But I would think from the acute trust and the effects on us, you're talking 2 to 3 years to work our way through all these changes. But don't hold me on that.
And then with regard to the community services, as Stephen mentioned, we're looking to make as much headway as we can on the integration of care, because that doesn't need consultation, and our clinicians are saying they want to do it, and it seems like the right thing to do, working on the back of the experience we've had, for example, trying it out in Millham, for example. It looks like the right thing to do. So we're trying to get that moving as quickly as we can. So that would be immediate. In terms of the changes to the community hospital beds, we'll be looking to try and adapt some places for those changes. There might be a little bit of work required in some of the units, but subject to the outcome of consultation, we'll be looking to make those changes in the first year or so following the consultation, so that we could crack on with the new model and improve care as quickly as we possibly could. If we can get the integrated care working, then that would help us do that.
Okay, there's a gentleman in the white jumper here.
I would just like to ask a question from the ambulance service. Healthcare for the future. What is the future for the ambulance service? What are your predicted response times now, and what do you think they might be in the future? We've heard that Millham are looking to get the ambulance in Millham in a better location, but I've had the misfortune to need emergency ambulances twice in the last 3 months, and it's taken over an hour on each occasion for it to come. Population's increasing, we live in a rural area, roads are getting busier. What's the thinking for the future from the ambulance service?
Right, if I can break that question down. As far as response times are concerned, they remain the same as they've remained for a long time now, and as far as I am aware, there are no plans to change them. The response time is that we need to respond to what we would code as a red 1 call, which is the most life-threatening conditions within 8 minutes, 75% of the time. We don't achieve that in North Cumbria. Red 2, which are still life-threatening but of some lower acuity, we have to respond to within 8 minutes, again, 75% of the time. We don't achieve that either. And then we have the 19-minute response, the A19 response, which we have to respond to in 19 minutes, 95% of the time, and we don't achieve that one either. There's a recognition that we don't achieve it because it's due to geography, and essentially that response time was set up for an urban model. So we have a number of initiatives to try and achieve it. I don't know what it will be for the future. There's a number of things that could bring about a change in targets, not least the political climate. We have recently changed the way we code, literally just changed it last week, and that is now called dispatch on disposition, DOD. And we've changed that subtly so that we now dispatch an ambulance based on clinical criteria. There's been a suggestion, and it's probably not wrong, that it's target-driven, not people-driven. The thing is, if an ambulance gets to you in 8 minutes, it is people-driven. You can't say that's wrong to get there. But now we've subtly changed the way the questions are asked, so that one primary question used to be, is he breathing? Is the person breathing? And we would get a straight yes or a straight no. Now we've changed that, so is the breathing noisy? Because that could change the triage system of how we respond. So that has changed, and what we see there is that performance does improve, and we're also getting to patients based on clinical need. But to be honest, we've still got, because we only initiated that last week, we've got pilot sites across the country, although it's a strange pilot when half of the ambulance services in the country are doing it and the other half aren't. But we've seen good results across the country, so that's what we do. That's what we're doing in terms of performance at the moment. In terms of weights, I do completely take your point. And it came home to roost when I had to wait an hour with my own mother while she was having a heart attack. And that was in the centre of Carlisle. Now, the reasons behind that, they're not because we're not very good. They're not because of that. that because we've seen in North Cumbria especially, which is higher than the rest of the Northwest, we've seen a 20% rise in activity in the last year. Our ambulance stations are where they've always been. You know, we've got physical buildings in a number of places, and here you're in between Brough Ambulance Station and Penrith Ambulance Station, and there are no plans to do anything with those stations other than keep them where they are. But what we almost do, those ambulance stations now, if you think back 20 years, we would have ambulances on those stations ready to respond, because the activity was low enough that we could do that. Now we operate what's called an ambulance response program, and we have them almost, if you watch them on a radar, they would just be doing that all day, and we just move them around, because we know that hour by hour our predicted activity changes, and where we are likely to be required changes. So it's things like, and it's really quite interesting, at least I'm interested, it's things, it changes in the school holidays, because the activity, the population moves in a different way. So any day of the week now, we know our peaks of activity will be between 7 in the morning and 10 in the morning, because there's more people out there likely to meet with misfortune. We know that increases again between 4 o'clock and 7 o'clock. And we also know that there's an almost crisis point, probably mid-afternoon, when GP admissions have started, and we essentially almost add to the problem of the acute trust. And we recognise that because we're admitting people, and that creates a capacity problem within the hospital. So we know we've got those areas during the day when bottlenecks can happen, and we might run out of ambulances. And we do run out of ambulances. I'm not going to say we don't, because we do. And it's a very, very nerve-wracking period when, if you sit in our operational control centre, watching those incidents, waiting for vehicles. I don't know whether any of you have been watching the London Ambulance Service programme this week, but it's been really interesting, because that's going on all over the country. So it's a question of, we know that people aren't going to stop ringing for ambulances, we know that. So it's about what we do with that activity to ensure that we are available for those serious life-threatening calls when we need to be. And part of it is what I've already spoken about. So it's about seeing people in their own homes, because it's got to be better that people stay at home. You know, nobody willingly goes to hospital. The only time you sort of go willingly is when you don't know you're going. And it's got to be better that we keep people at home, because we also know that the elderly actually get better quicker in their own homes. And it's good for your psychological well-being. It's good to be close to families. But it's also good, you know, let's make no bones about it, it's also good to have ambulances available, so that we're not going up to the Cumberland Infirmary, or we're not going to West Cumberland Hospital. So we've developed some initiatives.
The point in issue that I appreciate ambulances are being pulled, and there could be somebody in Penrith taken to Carlisle Hospital. If it was a fire situation, I believe a neighbouring fire engine would come into that area to cover that slot. On my two occasions, where on one occasion the GP was with me for the best part of the hour and liaising with the ambulance service, the ambulance was coming from Carlisle, and that took an hour and 10 minutes. On the other occasion, came from Lancaster. Now, I may have been unfortunate, but there wasn't an ambulance in Penrith. So it begs the question how many ambulances there are. If it had been a major accident or whatever, what would be the outcome there? And we talk about the golden hour in the stroke situation. If an ambulance is coming from Carlisle, the hour's gone before it even reaches. The guys that came were absolutely outstanding, brilliant, and did things the GP couldn't do. But it does put fear in me of what the future is, and that's why I ask, what are the thoughts for the future? Can that situation be given a little bit of serious thought?
That situation is given serious thought.
I'm sure it is.
I don't want to downplay what the fire service do, but they're not as busy as us.
No, I appreciate
So they
that.
can,
I appreciate
that, you know, they can have the amount of calls in a year that we can have in a week. So to ask for a neighbouring ambulance service to help us would be out of the question, because they're all under equal or worse pressure than we are. We can ask for mutual aid in times of crisis because we can invoke the Civil Contingencies Act. So in times of flooding, etc., it's perfectly reasonable to ask for help from neighbouring ambulance services or the military. In terms of the number of ambulances available, we've increased that. So by some amount, actually, we have increased the number of vehicles, vehicle hours that we have available. The problem we have had, which I'm really happy to say is now resolved, is the number of vacancies we had. At one point, only 4 months ago, 3 months ago, I had 43% vacancies on paramedics in North Cumbria. For a variety of reasons, we were experiencing the same recruitment problems as our other health partners. And that was causing us problems because we had the ambulances available, but we didn't have people to put on them. But we were doing everything we could. We invoke a rule where managers have to respond. Managers are responding just the same as anybody else in cars, and we will ask for that too. And we would stop all non-essential meetings, etc. What we've done now is we have recruited an additional 24 EMT1s from the local community and beyond, actually. We've got somebody that's going to commute from Lincolnshire. And we've also done international recruitment. So we have recruited 12 paramedics who have started this week, all from Poland. And the reason we've had to recruit internationally is because there aren't enough paramedics in the UK to be able to, every trust is vying for them, and there just aren't enough. So we've recruited 12 paramedics from Poland. The reason we went to Poland is because their standard of education is higher than ours. So we've got some very clever people just started this week, all with master's degrees, etc. And we have recruited a further 16 who will be starting in January. So what we'll see now is all those ambulance hours will be full. I have to say I'm really sorry you had to wait. I am really sorry. I am a Cumbrian through and through, and it's not, I know that feeling of having to wait. An hour feels like a week. So I hope that we will resolve that situation very soon.
I wonder, I think there was a further question from yourself. I wonder whether the good news about recruitment is something that the rest of the panel kind of want to reflect on, because I know when we've talked about this, the pressure that the system is under because of recruitment is obviously something that the Ambulance Trust have felt as well. They may have found a solution. Is that something that the panel want to perhaps say a little bit more about in terms of that is a driver of the whole redesign?
I have to emphasise it's not the only driver of the redesign. I think recruitment, however, remains top of our list. I mean, there's two ways of solving this for us, is changing to different models that don't have so much emphasis on medical staff. So that's the first way we're tackling some of our recruitment issues, particularly physician associates who can work under supervision as if they were junior doctors. But also, we have made significant efforts in the international market, local advertisement, recruitment enhancements. We don't make any significant traction with certain specialties because, believe it or not, it's not just national shortages of paediatricians, it's international shortages of paediatricians. So there is an international shortage of many of the medical professions. Few reasons for that. One is the sheer cost of training doctors around the world, but also in the UK, trying to match the training with the needs. And, you know, as I mentioned earlier with the paediatrician issue, is as expectations have changed as well, and as how workforce have moved towards a greater work-life balance, the number of people we need to employ to deal with rosters and the workload has increased. So our recruitment hasn't been as successful, and we have tried Europe and beyond India. It's patches, you get bursts, and then people come, they often leave. There's a number of reasons why they do that, often going back into more urban environments. So that's the reality of the situation, but we are making huge efforts to recruit.
Okay, just looking at time, we've probably got about 20 minutes before I ask the panel just if they have any final thoughts that they want to make. So we've got 20 minutes left of questions. So this lady's got a question.
Thank you. I must say I've enjoyed ambulance too. Really impressed with it. I listened to the radio this morning, as I'm sure you did, the report about the state of the care homes in this country, and they reckon it's on the verge of disaster. And we've got private care homes closing, so you've got more and more people coming onto the system. You've also got local government responsible for care homes. They're pushed for money as well. I think you're going to have an awful lot of people coming on to your integrated communities. Aren't you going to need the beds in the community hospitals to help deal with all these people?
No, it's really very, very reasonable points made there. I think the broad themes that we're trying to tackle to deal with that problem, I mean, there's a number of issues that I guess as a society, that we're an ageing society, and certainly we have in this area, we have a large number of people living longer, inevitably, which is a good thing, but inevitably that can mean, particularly in people's last few years, they have a high level of needs. What we've found in Cumbria in the past is that compared to other parts of the UK, we will often look to accommodate people earlier, and people will be less independent more soon as they get older and get into those last few years. So very much what we're looking to do is to support people remain as independent as they can be for all the right reasons for their health and well-being, so that we've got as few resources as possible tied up in that long-term care, and as much resources that we have able to help communities with as much support and care as possible. And if we believe we can get that balance right, more right than it has been in the past. Now that's quite tricky, because in Cumbria we're all spread out in lovely areas where our towns are dispersed, etc., which adds to our problem. It would be probably easier to do that in an urban area than it is in a rural one. And of course, not all of the providers are people like our organisations who effectively are government organisations. Quite a number of the providers are independent sector providers and things like that as well. So there's certainly a degree of market management to be done to help providers come to places and stay with a good way of doing so. So there's quite a lot of challenges for us in that regard. You're absolutely right. We think if we can get the balance better, so that our resources aren't tied up as much in that long-term care, but more available to people in their communities, then we can support them better. And us and the local authority are trying to do that. And we think we've got room to get that balance better in Cumbria than we have in the past. But I don't take away the fact that it's a heck of a challenge. I think it's a heck of a challenge for our country, not just for us here.
Okay, a couple more now. There's a lady here.
I'm very much aware that in Cumbria, a very large burden is placed on the health service by people who have severe alcohol and drug problems. This is a growing problem all over Britain, really, for the health service. And in a way, can't be solved by clinical means, but it is social. That's the first part of my question, is what provision is being made to deal with that burden on the health service. The other one, of course, which hasn't been mentioned at all, is mental health services, which are a significant, again, a significant factor around here.
Start on those ones, and I think it's well known. I think that alcohol and substance misuse type problems, are a burden on health services, and certainly that is the case here. Substance misuse, I would include tobacco in that. I think we want our population to be as healthy as possible on all fronts. Putting that to one side, though, I think we know, and our clinicians tell us, often our primary care clinicians and our hospital clinicians certainly tell us that certainly alcohol misuse is a big issue. And there's a number of approaches there that we need to adopt. Certainly there are some national ones around, safer drinking, less harmful drinking, those sorts of campaigns, which we would look to fully harness locally. But over and above that, brief interventions where people who come into contact with services, you might have an appointment at your GP for something, a small ailment, but if the GP can advise you on the best way not to drink harmfully, that can often stay with people, and they can use that then in the way that they then consider their drinking and things like that. So brief interventions where every health professional doesn't just think about the one thing that they're trying to treat, but thinks about the whole person and perhaps provides advice on the lifestyle that person might have as well, if that's required, is a good way to do that. So we're trying to make sure that where possible, we get all of our professionals to offer that brief intervention, that brief advice, so that people are more aware of their lifestyle and the way they can improve it. And in addition, for people who perhaps have very harmful problems in terms of either misusing alcohol or substance misuse, we obviously have services where we can try and help people overcome that. I think it's fair to say that that's an area that we'd like to develop further. It's not an area that is commissioned for Cumbria through the local CCG. It's more commissioned via our public health colleagues, but we do try and do as much as we can in that field. And then the second part of your question was about mental health, I think. And this consultation isn't specifically about mental health services. However, we know that somebody's health includes their mental health as well as their physical health. So whilst we're not specifically consulting on any changes to the types of mental health services people might be referred to if they're particularly unwell, we know that people will have common mental health problems. In fact, 1 in 4 of us at some point in our lives might have a common mental health problem, things like anxiety or depression, those things. And indeed, in older people, clearly dementia is something that's often a very, very real diagnosis for people. So what we're trying to do there is, particularly working with primary care and GPs and the wider community workforce, is make sure there's a big, as much as possible, an awareness of mental health, that people take a holistic approach where they consider the whole person, where perhaps we intervene earlier so that we can try and help people more soon. There are a number of programs, for example, improving people's access to psychological and talking therapies rather than just relying on drugs, treatment drugs, or equally for dementia, trying to intervene early so people have good information about what dementia is, what they can do to adapt the way they live and the support they might need, and plan in advance, those sorts of things where we know that can very much help people with dementia. And the other thing we're doing is we're trying to increase the way in which people who are old and in hospital and may have a mental health problem, be it a common thing like depression or be it something like dementia, we're trying to ensure that our mental health workers go into hospitals more, help educate the wider staff in hospitals about mental health, so there's more understanding and more appreciation for the needs of people, but also connect those people, perhaps who didn't have a diagnosis until they went to hospital, where their mental health problems became more evident, get the right help they can from mental health services. So all of those things are the things we're trying to do, and particularly we know that one of the things that can cause people to be in hospital for a longer period than they perhaps might want to be is because they've got a mental health problem like dementia that hasn't been properly treated or diagnosed in the first instance. So spotting it early is key. And our approach to the integrated care community way of working is to try and make sure that our mental health services are very connected in with the local services, because we know that one of the biggest causes of poor well-being and ill health in a community will be mental health, and it's more common than perhaps people would think.
Okay, can I just go through a final kind of check with people about the consultation areas, just to make sure finally that people have had a chance to have a say, because I think we talked about a number of things which are kind of outside the scope of the consultation but are important to you, and I'm sure the panel are quite happy with that. But are there any final questions around children's services? Maternity? Sorry, there's a hand up. Thank you.
Yes, I was a health visitor in the area. I'm now retired. We did have a very good team of midwives and health visitors. We worked very well together. More recently, the numbers have declined. Staff numbers have declined. One of the questions I would like to ask is, where are mums going to go for their antenatal and their postnatal care? We used to do it in the community. Is it going to be a medical?
Well,
so we've talked a lot about acute services, and so we've talked about antenatal and postnatal over on the West Coast, but what's going to happen in this area?
It's a good point, and I mean, as I commented earlier, there's background things which need to be done. It's a bit like the mental health aspect that aren't referred to in this consultation, but would be seen as things which we would either take back from this meeting. So what I'm really indicating is the antenatal care, with the increasing sophistication of antenatal testing, some of it has to be delivered within brick walls, but also I think if we can go back and redevelop some of the community midwifery, which I know is one of the aims of the head of midwifery for the Acute Trust, we would inevitably go back and improve those antenatal services where they're appropriately delivered in the community. So I can't give you a precise answer to what's going to be where for antenatal care. What I do know is some of it's very sophisticated testing, ultrasound machines, and some of it's simply coming out and working in the community, particularly with the more disadvantaged,
yes,
the younger population and things. So I think that you will see changes back to probably something you remember.
The technology only tells you so much. You learn an awful lot by going into people's homes about that lady, about that person.
Yes.
And the other question that I wanted to ask you was actually about home births. You did mention the Cumbria report, and as I understand, I think a woman has the legal right to give birth in her home. I may be a bit behind the times, but I think I'm right in saying that. So there may be difficulties there in this area, and I'm talking about this area because we've talked quite a lot about acute services. We're very rural. I would have liked to have seen somebody from the social care here, because in fact lots of the community services rely on the social care, and there's a big knock-on. If they can't do their job, we can't do our job.
I think we've made a comment elsewhere about wanting to make sure that the social care colleagues are a bit more visible in the kind of the partnership when they come out. But in order to get a full answer to the question, Rob, would it be all right if we asked for an answer to that to go on to the FAQ section?
Yeah, I was going to say, I think, there are things which I'm not going to be able to answer right now, but we'll take those back and see if there's an answer to how how the maternity services see themselves developing for antenatal care more in the community. Is that all right? Yep.
So you'll see it on the website under the FAQ. There's a tab. Is there a tab for FAQ on the website? There is. Okay. Was there anything else around maternity? Okay. Community hospitals and inpatient beds. Gentleman here.
Your report suggests, well, it more than suggests, that all of the options result in a closure of 29 beds. What consideration has been given to the fact that there's so many of the community and the care homes closing? Here in Appleby, we've just lost Edenside. That's care in the community. The people that have moved out of here to Greengarth are suffering as a result. The county council's carrying out surveys or consultations to close even more in the Carlisle district and the Copeland district. If the consultation follows the path that I suspect, that will result in at least halving the number of beds provided by the council. Private ones are closing. I suggest to you that by closing 29 beds in the community hospitals is short-sighted.
Try and respond to the point there. So at the moment, in the whole of West and North and East Cumbria, our community hospitals have tried to maintain 133 beds available to the public to be used. And we haven't been able to maintain 133 beds open. At the moment, we're having the order of about 111 open, and that's largely because of difficulties recruiting staff, which are not recent, but long-standing difficulties. So we're running with around about 111 beds at the moment, and the proposal is to have 104. But you're absolutely right, we're proposing to do that over less sites by focusing on 6 rather than the current 9. We think that's appropriate because we think we can maintain higher quality care with more continuous staffing and for those staff a less isolated practice, which will mean that we can retain staff as well as train new staff more effectively. But nevertheless, that reduction in beds clearly means that we're going to have to try and make sure that we treat as many people as we were before, but perhaps with a shorter length of stay. On average, people stay in community hospitals for only 20 days. So community hospitals are not a place where people live. They're not a place that is the same as home. They're still a relatively short experience, although an important one. So we don't believe that you can equate a community hospital to the same as a care home, where people will live, often for a number of years. So we think if we can reduce the numbers of days people are in hospital, from 20 maybe down to a better standard in the order of 16 or something like that, we think we can treat as many, if not more, people in our 6 remaining community hospitals because they'll be more securely staffed. Having said that, I think there is a very real issue behind the question with regard to can we cope with the burden of care that will be required in communities with a shrunk down, if you like, degree of accommodated care in social care and across health. And I think we can only do that if we work with communities to try and make sure that we get the best and squeeze the best resource possible from what we've got by working together, integrating what we do, not duplicating or leaving gaps and wasting our time, but trying to ensure that we work to get the best care possible seamlessly provided, and that we release the resources where possible to get ahead of ill health, do better care planning and avoid people getting into crisis in the first place. So very much that integrated way of working, we think, is the key to unlock a better result from our existing resources and cope with the challenge that you've obviously been able to describe in the question that you put.
I'm sorry, but you've not really answered the point in terms of where are the people that are otherwise in a care home, where are they going to go in future? You're not providing for them. they don't choose to go into the care home, generally speaking, they have to go in.
And what we found in working with our local authority colleagues, what we found when we look at our practice here in comparison to other parts of England is that because we haven't provided the seamless support for people to be independent, they generally will find themselves going into homes more soon than otherwise would have been the case. So what we're trying to do is to help people be as independent as possible for as long as possible, so that we can shift that balance of resources from care homes to those services closer to where people want to be and be as independent as possible. And that's the balance shift that we're trying to bring about.
Did I hear somebody say that social care have a consultation of their own going on at the moment? So those kind of points about if you're shutting care home beds, what are your plans, would also be voiced within that consultation. Say again, sorry? Oh, right, okay. Stephen?
We'd be happy to take that question back to local authority colleagues, though, and get a view about the care home or the care bed capacity in this area. And I think it's also important to point out that the impact assessments of the changes that are being proposed are ongoing. So as, for example, new issues are brought to our attention, then we will go back and refresh the impact assessment to understand whether the community hospital bed base, which is proposed to change, could actually make a difficult situation worse in the care home sector. So thank you for raising it, and we will look into it. And again, it's probably one of those responses that we would look to take back from the local authority to put on the website under the QAs.
Okay, so I think the final couple of areas were emergency and acute care. Any final questions on that? And then finally, hyperacute stroke. Okay, so people feel that they've had their say with regard to kind of those matters that we really needed to get your views on. Could I ask the panel just if they want to make a final kind of take-home message for everybody, and then we'll kind of wrap up. Anybody want to start?
I'll just come back to the question that was asked to Carol around ambulance services and what's going to change. And Carol mentioned 20% more activity. I can give you another statistic. In North Cumbria Hospital, year on year, as of August, nearly 15% more activity going through A&E. That's over 4,700 additional contacts in the accident and emergency department in that hospital. And coming back, linking that back to your point about, well, why now? Why are integrated care communities going to work this time around? And I said, well, look, there's a pressure building in our system that means we have to do it. We have to make it happen, because Carol services can't be sustained. Not everyone that's calling for an ambulance would necessarily need it if we had better coordinated care in the community to meet the needs of the more vulnerable, the frailer patients that need that care. So that's statistically, if you like, why there is this imperative to make these changes.
Okay, Rod, are you next?
Yes, I mean, from my point of view, some of the changes are an imperative for delivering more modern healthcare as well. We've talked about the rising admissions, but also we have to look at the reality of trying to deliver very high complex care in some cases with a workforce that's very difficult to recruit and basically are highly skilled. They can go anywhere in the country and the world to that point. So it's about getting the balance right, trying to consider, as has been eloquently said, improve care at the home for less complex conditions, but also trying to take us into the more advanced care that we can provide, at least in one centre in West, North and East Cumbria. So that's my plea, is to read the consultation document. I appreciate the subsidiary documents, and they'll be improved as we go along, because I've been asked a few questions already today that haven't been asked in other places, and we'll need to go back and put the answers to some of these on the website. So thanks very much.
Michael?
I think I'd reflect that the questions put tonight have been extremely pertinent, and I don't think we can solve this on our own. I think we've put some proposals to the public that we are very much interested in getting views upon, and that's a process of dialogue which I hope will become a process of co-production. So communities like here in Appleby can work with our local services to try and shape the future as much as possible, and we think that's got more in it in terms of a potential positive future than perhaps some of our working arrangements have been in the past. So very much that's the spirit in which we're trying to take forward the consultation, and hopefully you'll hold us to account for that in due course.
And obviously leaving the best to last. Carol?
I suppose it's about echoing what's already been said. 10 years ago, none of the health partners, we barely spoke to each other. We all worked in isolation, and we all sat there thinking, I don't know what's going on, what's the problem? Why can't they get their act together, essentially? And it's only very recently, in years, that we've realised it's actually a system problem. And one part of the system very much impacts on the other part of the system. And one can't succeed without the other either, because it's a bit of a conveyor belt. You know, the ambulance service, the primary care will see a patient or not see a patient or whatever. For some people, dialing 999 is a social activity, and we then have to manage that. We then have to manage those people, and if we've got a seamless system, which we haven't, we should aspire to one. And it's not necessarily about where the services are based, it's about the quality of the service. And I think that's all we're trying to do. We're just trying to get a modern health system and work with what we've got, because we'll never have enough money to do it all. We never will. It would cost too much. And the NHS has become almost a victim of its own success. It's such a upstanding, fantastic organisation. And when you see it working, when you really see it working, it's amazing. And I think it's just about, and it's about the people in it as well. So there is a real desire to make it work. And I think you've got to believe us when we say that. You really have. You've got to believe us when we say we want it to work. Thank you.
Okay, just a kind of one plea and one suggestion to finish. The plea is that this exists, and you can tear out the pages and there's a free post, or you can send in something that's covering the same kind of area but doesn't actually have all the bells and whistles completed. Your views are important in a sense in every which way they come in, and we've already heard how they're going to be taken on board, and a report is going to be produced, and you'll see that report at the end. And I think the final point is just a suggestion. Tonight you've talked about things which are kind of outside of the consultation that bother you. You've talked about drug and alcohol services, mental health services, community nursing services, access to primary care, all those kind of things. It might be something that perhaps in future you might want to ask the CCG to come back and some of their partners and do something like this about general health services, as opposed to some very specific consultation items that we wanted to talk to you about tonight. So maybe that's something that the panel might want to think about. Thank you very much for coming. We're 5 minutes ahead of schedule. Thank you very much for coming, and I hope you have a safe journey back. Thank you.